Hi, everyone. My name is Hamera Osman. I'm the VP of Research and Public Policy at Muscular Dystrophy Canada. I hope you're having a good morning, if those who are joining us from the West, and good afternoon to those who are joining us from the East. And so today we're here for a Let's Talk Neuromuscular Disorder webinar, this one on new treatment and therapies to manage Pompe disease. I should mention that this really came from the research hotline where we receive questions on different diagnoses. And when it comes to Pompe, many are really interested in learning more about what is the current status around treatments and therapies, what's on the horizon, what's next. And so with that, of course, we have a neuromuscular expert and a researcher who's contributed to work in Pompe disease, Dr. Mark Tarnopowski. He's a professor in the Department of Pediatrics and Division Head of Neuromuscular and Neurometabolic Disorders, graduate of McMaster University, and has been a faculty member since 1996. Dr. Tarnopowski really focuses on innovative research on mitochondrial diseases, muscle disorders, and neurometabolic disorders. And as I mentioned, has been a strong proponent in terms of really contributing to research and clinical practice for Pompe disease. I can pass it over to you, Dr. Tarnopowski. We really appreciate you've done webinars in the past on Pompe, and we're really excited to hear more. I should mention that the first question in the Q&A is that someone loves your coffee. So over to you.
Great. Well, thanks very much for the kind introduction. And I'll go fairly quickly through some of these because we want to focus on treatment. And just one sec. Oh, why is it not advancing? There we go. So just from a disclosure perspective, I have been involved with some companies that have relationships to Pompe disease, and they're listed there. Most important of which is that I am the founder and CEO of Exerkine Corporation. And we are working on a variety of aspects related to obesity and aging. However, as you'll see, a lot of these are important to our patients. And we do have discount codes. We are giving away a lot of our product for free to those with neuromuscular and neurometabolic disorders. And we have discount codes for any patients through a variety of different patient support groups. So learning objectives, again, there's a lot of buzz about the new enzyme replacements that are on the horizon, and some have even been approved in Canada. There was a lot of buzz. One of my colleagues, Pranesh Chakrabarti, was on a paper in the New England Journal where they did in utero enzyme replacement. I won't spend too much time on it, but I'll tell you why that's interesting and what the advantages are. Talk a little bit about combination therapies, really, which is first, commercially available one is using a chaperone and an enzyme replacement therapy that Amicus Therapeutics has evaluated. But for me, a combination therapy is looking at the entire aspect of what might deleteriously affect a patient. And we'll talk a little bit about those things being sedentary, obesity, poor nutrition, nutritional deficiencies. All of those things I think are really important, not just for Pompe patients, but indeed for every patient with a neurometabolic or neuromuscular disorder. And talk a little bit about some of the future therapies, gene therapy in particular. There's some interesting developments there. It's not yet ready, but what we've seen in SMA, I think, gives us all hope and optimism that hopefully we'll have similar benefits in Pompe disease. And then I'll just summarize with what is the way that we can holistically look at patients with what we have now, with hope to the future to treat our patients. So for most of you, you know that Pompe disease is a mutation in the GAA gene. This gene encodes for acid alpha-glucosidase. This is not a glycogen storage disease. It is a lysosomal storage disease. So unlike all of the other glycogen storage diseases where there's a mutation in an enzyme which is important in metabolism, this is an enzyme which is within the within the lysosome, and its sole purpose is to break down glycogen, which accumulates in lysosomes as they go about their business, taking care of oxidized proteins in the cell. What happens, however, if you can see here in purple, these are contractile elements of muscle, the actin and myosin, and these sort of pink areas here are glycogen. So you can see that if the lysosomes expand, they can displace the contractile elements. And of course, this person has about only 40% of their muscle left. It's going to get weak. So stylistically here, as these lysosomes increase, it displaces muscle. But also they can break open. And we know that there's a variety of proteolytic enzymes in their low pH, i.e. high acid content, and that can damage skeletal muscle. So, of course, the protein manifestations that we see in children are hypotonia, which really is the infantile equivalent of muscle weakness. And in our late onset patients, we see muscle weakness, which we'll talk about. So progressively, as we further damage the muscle, in the infantile disease only, we see severe cardiomyopathy. In both of these, we can see respiratory insufficiency, sometimes requiring mechanical ventilation. And even in the late onset form, it can lead to early mortality through respiratory involvement and consequent issues like pneumonia. So it is a real continuum. And to a first approximation, this continuum with respect to the age of onset, the classic manifestations of the IOPD or infantile onset versus the late onset really come down to how much residual enzyme activity you have. So everyone's aware that every mutation in a gene may have a different deleterious effect on function. For example, if we have null mutations and completely eliminate the activity, then we have extremely low levels. And what we and others have found is that when the residual enzyme activity is usually around 2% or less, we get the infantile onset form. And these kids usually present before 6 months of age with significant hypotonia. And sometimes, as we've experienced, they go in with a cough or a cold. Someone does an X-ray and you see that they have cardiomyopathy and they come in for that reason. Such was the case with a youngster that we just diagnosed with IOPD just 6 weeks ago. Who came in and they incidentally saw that there was a enlarged heart. Retrospectively, the child had hypotonia but hadn't been referred. And of course, if children are diagnosed after 1 year of age with this disorder, even though there's a huge spectrum from these younger children, just sort of semantically, they still call this late onset. But of course, this is sort of an intermediate form where children have weakness in childhood, and we have several of these patients as well. And unfortunately, they usually do go on to require assistive devices, often similar in some ways to Duchenne, a fairly early onset of weakness. Of course, we've seen patients as old as 72 coming in for their first diagnosis of late onset. And these folks usually have residual enzyme activity in the sort of 30% range. So again, the higher your enzyme activity, the later is the onset of symptoms. And in the adults, it's usually either coming in with respiratory issues, shortness of breath on exertion, and sometimes even in frank respiratory failure and proximal muscle weakness. So what are the clues for a clinician to think about someone having Pompe disease? At the time of diagnosis, everyone will have a high CK. I know there's papers and people say, you know, the sensitivity is not as great and you can't have normal CK, but that's if you follow patients for a long period of time. When their muscle is damaged, they can have a normal CK, but at the diagnosis, all patients will have a high CK. The muscles that are affected, generally the scapular muscles, and it's important to look for these. One, you know, think about FSH1, FSH type 2, calpain 3 deficiency, and Pompe. Those three look very similar, and you've got to look for it. So what you do is turn the person sideways, put the arm forward, and push up. Because when their arms are in tight, sometimes the muscles feel great, but it's only when you put the arm up that you see that there's this scapula that starts to ride up. That's a big thing to look for, to think about those disorders. The other interesting thing is the adductors are specifically affected, and many of the patients, when they walk, their legs will splay out as they're walking. The other important point, too, is that the lower paraspinal muscles are often very affected. And some of our patients who are quite mild, if they're sitting in a chair, your MRC grade can look perfectly normal, but watch them walk and you'll actually see that sort of waddling gait because of the paraspinal weakness, and a splaying often of the legs because the adductors can't keep the legs going straight. There's usually respiratory symptoms. So invariably, most of our patients have shortness of breath on exertion, or orthopnea, or paroxysmal nocturnal dyspnea. When you do an EMG with the needle, usually we'll see what are called active changes. So fibrillations, positive sharp waves, and then small, brief early recruiting potentials. And a number of patients that we and others have seen were first labeled as having polymyositis because they have proximal weakness, high CK, and an EMG that looks like it's an active myocytic process. So the EMG does look quite active. But in these patients, of course, it's important to identify them, because treating an inflammatory myopathy patient is very different than treating a patient with Pompe disease. There can be other features that we and others have seen. Certainly, about 20% of our patients have ptosis, often unilateral, sometimes can be mistaken for myasthenia gravis. And you can see ophthalmoparesis. When you see it, keep in mind that some patients can have a basilar artery aneurysm. And we actually had a fellow from Windsor just a couple of years ago, and that was the presentation. And sure enough, when we did an MRI, we saw that they had a basilar artery aneurysm, which was causing the ophthalmoparesis. So keep that in mind. So let's turn to what this whole talk is supposed to be about, which is the therapies. So assuming that you have a confirmed genetic diagnosis of Pompe disease, what can one do to treat a patient? So we'll talk about the canonical therapy that people use, which is called ERT, or enzyme replacement therapy. To a first approximation, essentially what they do with this is you generate the enzyme in vitro. So you have a bioreactor, which essentially is a bunch of cells. In this case, it's a Chinese hamster ovary cell. It's in a culture media. The culture media then, because they're genetically engineered to produce GAA, will spit this out. And then you can extract it from the culture media, purify it. It comes in a desiccated vial. You reconstitute it and infuse the native enzyme back into the individual. So that's depicted here with this blue. The acid alpha glucosidase, in this case, myozyme, which was the first one that was produced by Sanofi Genzyme, binds to what's called a mannose-6-phosphate receptor, and they can also bind to insulin-like growth factor receptors as well. But mannose-6-phosphate is the main receptor to which this enzyme binds. It can be internalized into an endosome. Endosomes can fuse with a late endosome and be spit out as exosomes, but more commonly, they fuse with a lysosome. So this is how something coming into your vein actually can be taken up into your skeletal muscle and then eventually into the lysosome. How it works is once it's in the lysosome, it can do its native activity, which is hydrolyzing the 1-to-4 and 1-to-6 glycosidic links, breaking down that glycogen to glucose so it doesn't build up in the lysosomes. So does this work? Well, we know that this works based on a randomized double-blind trial published by my colleague Ans van der Ploeg in New England Journal of Medicine over 13 years ago. So this was 90 adult onset patients of the late onset Pompe disease, and they had co-primary endpoints. So 6-minute walk test, which I'm sure all of you are familiar with, and forced vital capacity. They gave them the standard dose, which we all have been using for our adult patients, 20 milligrams per kilograms every 2 weeks, and followed them up at 18 months. And as is the case pretty much with every neuromuscular disorder, those who are less affected at baseline tend to do better. And that is, if you have irreversible end-stage damaged muscle with scar tissue, there's no going back. It's the same with SMA. Once you've lost those nerves, you can't recover nerves that are lost. So what did they find? So forced vital capacity, there was a 3.4% difference between those treated and those not treated at 18 months. And if you look at the 6-minute walk test, you can see that there's a 28-meter difference between those treated and those not treated. Now, in some studies, people have mapped this out before ERT and showed that generally people lose between 1% and 3% per year. In a study, patients are usually doing a little bit more activity, and so we didn't see the typical loss. But still, since everyone was randomized and double-blinded, which is the only way to believe a study, you can see that there is quite a difference here. And when I say that about the only way to believe a study, unless there is an absolute amazing effect, which actually was the effect of myozyme in the infantile patients, where essentially 100% of children were dead by 18 months, but with the enzyme replacement therapy in the first study, essentially every child survived, which is really similar to the fact that you didn't need a randomized trial when you look at gene therapy with SMA in the infants. It showed such a dramatic benefit that a randomized double-blind trial was not needed in those circumstances. So what do we know now that we've been using this drug for, in our case, 12, 13 years? Pretty much everyone has had this experience with at least 50% of your patients. What you see is that after around 5 years, we get the initial benefit, and then we start to see that they follow their typical trajectory that they were on before they were treated. And one can see that with 6-minute walk test, and it's also the same for forced vital capacity. So this is natural history, and then you go on therapy, and then eventually you start to come down. So essentially what's likely happening is usually after about 5 years, people are getting tachyphylaxis, whether it's receptor downregulation or whatnot. Clinically, people start to continue to plateau. And at that point, the question is, what are you going to do about it? Because at that point, the drug is probably fairly ineffective. Are there other treatment options? Is there any way we can boost the benefits of therapy? What can be done? So what the drug companies did is they said, well, let's, knowing that the patent's going to run out, let's see if we can come up with a new and improved enzyme replacement therapy. So the two main companies that were looking at the new ERT was Sanofi Genzyme and Amicus Therapeutics. So Amicus's approach was to use what's called a chaperone. So essentially the chaperones, which are extracted essentially from berries, cranberries in particular, what they do is they're mild inhibitors of the enzyme, which you might say it doesn't seem to make sense, but it can sometimes change the conformational shape of the enzyme and or prevent it from undergoing denaturization. And this was one of their early studies where they showed that if you have a recombinant GA enzyme alone, and then you add different chaperone concentrations, you can see that the area under the curve increases. So this is the ability of the molecular chaperones to bind to the recombinant enzyme and keep them from denaturing in the non-native environment. So a lysosome is 4.2 pH, our blood is 7.4. And so this did show that you have a greater area under the curve, and therefore greater time for the enzyme to interact with mannose-6-phosphate receptors and get taken into the cell. So that was a study we were involved in doing muscle biopsies on folks. It did show that we did get a greater area under the curve, but what we care about are clinical trials. So they did a randomized phase 3 clinical trial called PROPEL. This has been published. FDA approval was approved in the States just recently, and I believe it's under CADITH review at this point. So what they did is that they had patients in a phase 3 RCT who were greater than 18 years of age. And they had two groups. One were ERT naive, so that as people were being diagnosed during this study, they could be randomized to placebo, to myozyme or to their combination. And they also had the experienced patients, and that was patients who had been on myozyme, who then entered the study and then got randomized to either stay on myozyme or to their new combination, which really was their own form of recombinant GAA plus a molecular chaperone called miglustat. So they did 52 weeks blinded, and then an open label extension, which is still ongoing in this study. So the endpoints, primary was 6-minute walk test, and the secondary was forced vital capacity. So when you look at all comers, so that was either the treatment experienced or treatment naive patients, what they found was they missed their primary endpoint with the 6-minute walk test. So as you know, you need 0.05 to be significant. I believe their stock dropped 21% when this was announced because they missed their primary endpoint. But again, it was a little bit of voodoo, flip the coin. Which one do you go for? Do you do 6-minute walk test or forced vital capacity? If they flipped the coin in the opposite direction, their stock wouldn't have dropped because they met the primary, their secondary endpoint, which is forced vital capacity, was better for the treated patients. And then what's interesting and what I'm more interested in is what about my 20 patients who've been on myozyme and that sort of 50% who are now plateauing and no longer showing any benefit. Will I get benefit if I switch, meaning an experienced patient on myozyme plateauing, and if I switch them to this new drug, do I see any benefit? So in the switch patients, they showed that folks who'd already been on myozyme who then switched to this drug, there was a significant improvement in 6-minute walk test, and quite a difference in the spirometry. So those who remained on myozyme, which is pretty much what we're seeing now in some patients after 5 years or so, they continue to drop, but they stabilize that with this. So in my mind, that's certainly something I'm very interested in, is when you get tachyphylaxis to 1, do I have a drug in my quiver that I can then switch to to give people some either further boost or to attenuate the rate of decline. In the naive patients, it wasn't as striking as I think the company would have hoped for. The one thing that I'm very interested in is, if you recall from the original LOT study, this improvement in 6-minute walk test is very similar. So you're talking around 30 meters increase in 6-minute walk test. And these are naive patients who came in, got a diagnosis, and were randomized to either the ATGA, which is the Amicus product, or to Myozyme. So, they're all around 30 meters, no difference. So they didn't see that their drug was any better than starting a patient on Myozyme or this drug. And the same was true for the forced vital capacity. Keep in mind, this was a fairly small number of patients, but nevertheless, it does confirm that these drugs do work, but didn't show superiority of this over Myozyme in a de novo patient. So the other way that companies have looked at coming up with a new therapy, and of course, Sanofi Genzyme didn't want to lose their $1.2 billion market share every year. So they were working very hard for a long time, knowing that Myozyme patent was going to come up. So what strategy did they take? Well, what they did is they used genetic engineering to try and come up with a recombinant GA that had extra carbohydrate moieties on the surface. And the reason for that is that these specific carbohydrate moieties are the ones that bind to the mannose-6-phosphate receptor. So if mannose-6-phosphate receptor abundance is low, as it is on type 2 fibers, and you've got more carbohydrate, that does get taken up better. And they clearly showed in their mouse models quite a dramatic benefit with this neo-GAA, they call it, or Nexviazyme is the name they're now using, versus the original Myozyme. So this was a phase 3 multi-centered trial. We were part of this, and patients who were newly diagnosed were randomized either to receive Myozyme or this drug called AVA. Now we know it as Nexviazyme. And I don't know whether they knew what Amicus's primary endpoints were, but each company switched and they flipped the coin and they got each other's primary endpoint. So they chose forced vital capacity as their primary and 6-minute walk test as the secondary. So what they found here was, again, not good for the stock. So in their primary endpoint, they did not show superiority. So interestingly enough, very close, but it wasn't statistically significant. So this on top here is the AVA, and this is the Myozyme. So this is change in forced vital capacity over time. So they weren't inferior, so this was not worse than this, but it was not technically superior. And then there is an open label extension on this that's ongoing right now. So we will learn a little bit more about switching, because the patients who were put on Myozyme originally in this study for 1 year were then switched in open label extension to the AVA. The only thing that doesn't help me is, what about my patients who've been on Myozyme for 5 years or 6 years, and then we switch them at that point when they become tachyphylactic to the other therapy, because folks in this study were only on it for a year, still getting benefits. So they probably weren't seeing the significant add-on benefit of perhaps changing. So let's talk a little bit about some of the nuances of ERT. And again, I could talk 1 hour on each one of these, and we won't. I think the first thing that's important to point out is starting early in infantile onset Pompe disease is absolutely critical. And this came into sharp focus for me for 2 of the 4 patients that I've treated with IOPD, who came in the sort of age 5 to 7 range. The first kid I saw was 5 months. The other kid was 7. And these kids were hypotonic. They were floppy, but going through the system, they had not been referred to us yet. And both came in, one with an upper respiratory tract infection, and they saw this massive heart. And that's the picture I have here, and I'll explain that in a minute. And then we just had this a few weeks ago where a kid came in and was hypotonic, but actually presented with a cardiorespiratory issue, found to have a big heart. I saw the kid, clearly it was Pompe disease, and we've confirmed that. Now, my point here is this was a muscle biopsy I had done on the first kid, because at the time we weren't, this is almost 18 years ago, people weren't as attuned to this diagnosis. We didn't have rapid genetic testing, and there was still a number on the differential diagnostic list. So we did the muscle biopsy, sent everything else off, but we got this biopsy result within 3 or 4 days. And what it shows is that by 5 months, this kid's muscle is almost total sugar. And so the issue here, these are just contractile elements here, but all of this sort of homogeneous gray stuff is carbohydrate in lysosomes. And therefore, once we start treating, we've already lost a huge amount of muscle. And I still follow this child. He's a late teenager, but he's in a wheelchair, almost no movement whatsoever in the legs, very poor arm movement, severe oropharyngeal dysphagia and nasal dysarthria, but complete restoration of the heart. So the point there is, had these children been picked up, which I'll talk about in a minute, with newborn screening, they would have had the diagnosis, they would have been on enzyme replacement therapy earlier before this irreparable damage occurred, and we likely would have had much better benefit to their skeletal muscle. Again, there's a whole talk we could give just on the CRIM negative patients. What this refers to is patients that have two null mutations. So they make no protein, and so their body has never seen the protein. So when you infuse the protein, they have a huge immune response to it, and the therapy is ineffective totally. So there's a variety of interesting immunomodulatory therapies that have been implemented, really pioneered by Priya Kishnani down at Duke. The challenge, of course, is that these immunosuppressive therapies can seriously lead to increased risk of infection and other things. But that's one of the issues. Now, one of the interesting things that just came out, and I won't spend too much time on it, is the paper that you're all probably familiar with last year that really hit the press, where Pranesh Chakrabarty was involved in the care of a patient in Ottawa, where the family knew that there was Pompe disease. In utero, they knew that this child was affected. They knew that this child was CRIM negative. CRIM negative is a bad prognostic feature because they make essentially no enzyme, and they make these antibodies. So once they're born and you give them enzyme replacement therapy, you've got to immunosuppress them. So what was interesting is that in utero, it's sort of an immunoprivileged region. So they actually treated this child in utero. And this child, from my understanding, is now probably 15 months of age and developing perfectly normally. What's interesting as well is they didn't have to immunosuppress the child because they started the therapy in utero when there was not this immune response, so that as the immune system was developing, it had already seen this enzyme. The other interesting development, and again, don't have time to get too much into it, is that we and others are following the lead from the group in the Netherlands, where they're using higher doses in the children to try and get more enzyme in to preserve muscle function. And they are indeed reporting in several studies that with the higher dose, as you recall, 20 mg per kilogram is our standard dose. But in children, many groups are going to 40 milligrams per kilogram every 2 weeks, and in some cases, even weekly. So there's a number of us in Ontario who were talking about the possibility of adding infantile onset Pompe disease to newborn screening. I think it makes sense, again, when we look at the SMA experience, but there's a number of things that need to be considered. One, what technology are we going to use to confirm that they have IOPD? Because the last thing we want to do is that if someone's going to be, walking till they're 72 and then just have a little bit of weakness at 72 with a very mild form, is the test going to call those patients out? And would they then be receiving either gene therapy or lifelong ERT when they really don't need it? And some people say, well, you may as well start early. Who cares if you wait till she's 72? Well, it's $72 million to treat that patient. And number two, as we know, after 5 years of therapy, you start to become tachyphylactic to the therapeutic introduction. However, what we need to do, I think, is we know specific mutations, if they're null, cause IOPD. And these are things that we're going to be talking about as we work towards considering newborn screening in Ontario. It is available in several states in the US and several other countries throughout the world. And certainly from our SMA therapy experience, we think that this is interesting. So most of you are familiar with using AAV9, so-called Zolgensma for SMA, which has been the most exciting thing I've ever been involved in my life. I've seen at least 30 of our kids that we've diagnosed die with SMA type 1. In my career, we haven't had a child die in the last 5 years. And every child so far that we've picked up by newborn screening that we've treated with 2 SMN2 copies is developing pretty much on par. And our kids, once they're beyond 18 months, are all walking, which is amazing. So they have done some studies on gene therapy. in mice, and there's innumerable studies, which it would take a whole rounds just to talk about, where they've used different AAVs. And these are things that people are working on. AAV9 tends to have more tropism for nervous tissue, AAV8 for muscle and liver. And people have tried different promoters to, have muscle-specific promoter. They've tried direct injection versus a systemic injection. There's only one early phase 1 clinical trial evidence for the use of gene therapy in IOPD patients, where they were directly injecting the transgene into the diaphragm. The problem, of course, when you do that, a number of the patients develop pneumothorax, but there was some clinical improvement. Now, what I'm very excited about is when you look at what happened with Zolgensma and you start to see, what's coming out with the phase 1 trials in Duchenne muscular dystrophy, it makes me pretty excited that in the future, for example, if we picked up a child on newborn screening and they're pre-symptomatic, plus when it's much safer to give adeno-associated virus because of liver toxicity issues, I think that's where we're going to see quite a dramatic and significant benefit, in the way in which we're seeing that for SMA. So let's move back to some of the practical issues that came out of the ERT. Again, myozyme, the subsequent drug to myozyme, the AVA from Sanofi Genzyme, and the Amicus product. I think they hoped that one was going to be better than the other and they would take the whole market share. But to some extent, they kind of split the difference. One hit each other's primary endpoint. And so the challenge that we have is, which one do you choose when you're starting de novo? Hard to make a judgment, I think, at this point. The other issue, which is more pressing, I think, for a lot of us, is what about those patients, 5-10 years on therapy? What do you switch to? I think that the switch data will be more solid as time goes on for those on the next Viazyme, but we'll never get the answers that I really want. And that is, what about patients long-term on Myozyme, and then you switch from one to the other? I think biologically, it's most likely that they will respond to either. And it's most likely that whatever you switch them to over a period of time, they're going to become tachyphylactic to it. So I would like to have the ability in Canada to switch to one, and then if it stops working or doesn't work, switch to the other using objective outcome measurements. So those are things that we're going to have to be dealing with over the next few years. But what can we do now, and what other possibilities for the future do we have? So I think the easiest thing, of course, is exercise of any benefit. So we've published a review article, and you can see the reference here, where we've reviewed all of the evidence in Pompe disease, both from animal studies as well as human studies. And I'll show you those in just a minute. So certainly with endurance exercise, it's important because we know that that can improve your cardiovascular health and lower cardiovascular risk and lower the risk of obesity, which, as you'll see, is very important. And this is particularly important, Pompe disease, because about 60% of our adults do have type 2 diabetes, probably because the muscle is not as sensitive to pulling insulin in and they get insulin resistance. Endurance exercise, we know by activating PGC1 alpha can activate autophagy. And we know that autophagic block is one of the classic pathophysiologic mechanisms of the pathology of Pompe disease. In fact, Nina Rabin, who's one of the top researchers in the world in the area, thinks that that's equally important to the decreased enzyme activity, and that further impairs the disorder. And therefore, if we can activate autophagy, it would be helpful. We know with long-term endurance training, we can increase capillaries, and might that improve the delivery of an enzyme replacement therapy. Resistance exercise, we know in patients with the mitochondrial disease, Duchenne dystrophy, et cetera, that we can improve muscle strength. Exercise can improve bone mass, increases fat-free mass. And as we know, more muscle you have, the better you are at handling glucose, and you lower your risk of diabetes. So is there any evidence for this? Well, this is very open label evidence. And this was the first paper that came out of the group in Munich, Germany. They had 44 late onset Pompe patients who had been on ERT for a year, and they followed them for 12 months on therapy. And what you see here is they had a 6-minute walk test, and 5 of the patients in this group were doing regular exercise. So they did an hour of cycle ergometry during the infusion. And the thought there is that you would increase perfusion of the ERT to the muscle because you vasodilate when you're exercising. And 3 of those patients had regular physiotherapy. So what it shows is what was the trajectory over a year of treatment. And you can see in the dashed line here that the patients, all 5 of them showed benefits. And on average, these were some of the better responding patients here. So this is hand waving evidence, open label evidence. But again, it's not an expensive or risky therapy that exercise could be of some benefit. But what about more formal training and a better controlled study? So these are 2 studies summarized from a group in Greece where they had 5 late onset Pompe patients who had been stable on ERT for at least a year. They did in the gym supervised training with resistance and endurance exercise, again, starting very gently, taking a day off, gradually titrating it. And if anyone wants to go through exercise in neuromuscular patients, we have a YouTube channel that I've created. So if you type in Mark Tarnopolsky and the neuromuscular junction, you can see our YouTube channels as to how to exercise. So very similar principles that they used. And what they showed was a 15 to 50%, depending on the muscle they were measuring, increase in strength. And look at this, a 45-meter further increase in 6-minute walk test. Remember that, we pay $1 million a year per patient for the LOTS trial data, which was confirmed actually in the Amicus study, around 30 meters of improvement. So it's pretty potent, pretty inexpensive therapy. So that's the increase in the 6-minute walk test. And this has been shown also by the group in the Netherlands. This is Ans van der Ploeg's group, where they did physiotherapy in patients with late onset Pompe disease, 12 weeks, 3 times a week. Wasn't very aggressive therapy, not as aggressive as the Greek group. It was well tolerated, and people increased their maximal work capacity on a bike ergometer and their VO2 peak. So this is important because VO2 is an important determinant of aging. The higher your VO2, the longer you generally live. And we know that people who have very low VO2 have impairments in their activities of daily living. 6-minute walk test went up by 16 meters, and the quantitative muscle strength testing also improved for these patients. This is one of the earliest studies, which was done by Alfred Slonim in New York, and again, open label study. And what he did is he promoted the use of optimal nutrition, which to a first approximation is a high protein intake and exercise on a treadmill and arm ergometry. And he calls this NET, which is nutrition and exercise therapy. So of his 34 patients that he followed, 24 of them were compliant with therapy. So these are patients who were non-compliant, so they continued to show decline after he told them to exercise, but they didn't. Whoops. Oh, no, why is that now? I apologize. Anyhow, the patients who did exercise, there was a plateauing. So his suggestion was that regular exercise is important and a high protein diet. So what about diet? So we did a study years ago where we looked at dietary intake in our patients with muscular dystrophy, myotonic type 1, limb-girdle, FSH. And we've also done this on our Pompe patients, haven't published it yet, but the results are very similar. So we did prospective dietary records where we measured exactly what they were eating, and we separated them by 5 months so we could take the average, and we compared it to the dietary reference intake in Canada. So what we showed is that many of the patients are not meeting the minimum requirements for energy. But that makes sense, right? If you are in a wheelchair or you have to walk with a walker and you're not taking very many steps, your energy expenditure is low. And so obviously you don't want to eat too much or you're going to get obese. One of my limb-girdle 2A patients 2 weeks ago told me that she gets 100 steps per day. I didn't believe her, but she has a Fitbit, and that's her average step count is 100 steps per day. And as most of you know, most folks are trying to push for over 10,000 a day. And certainly the average sedentary North American takes 4,000 a day. So you can see why energy intake is low. But what does that do? What it does is it gives you very few calories to get the rest of your nutrients. So you can see all of these vitamins and even some of the minerals. If you're not taking in the energy, you're not taking in the appropriate nutrients. And important things like protein are quite low. So 16%, we're not even meeting the basal requirement for protein, which is 0.8 grams per kilogram per day. However, if we use 1.2 to 1.4 grams of protein per kilogram per day, which we suggest all of our myopathy patients take in, we're looking at 70% of patients are not meeting that requirement. We've also measured vitamin levels, and I won't get too much into this. Dr. Dodig and I are hopefully going to get this published soon. What we found is that depending on what you're looking at here, vitamin B12, about 15% of our patients are deficient. Vitamin D, this is with the rickets level of vitamin D deficiency, around 10% of our patients are deficient, which is a profound deficiency. However, if we look at current Canadian guidelines, 85% of our neuromuscular patients aren't meeting current Canadian guidelines for vitamin D. Now, you might say, who cares? Well, a lot of our patients are on drugs that can make their bones thin. And we also know, too, that severe vitamin D deficiency, less than 25 nanomoles per liter, can cause a myopathy. So identifying and treating that is low-hanging fruit in all patients. One of the things that we're interested in, we're doing more work on this, is the observation that a number of our patients appear to be skinny, thin, underweight, and yet when we actually measure them on a $200,000 machine called a DEXA, where we can measure how much muscle and how much fat they have, many of them are obese. So in pink here are our patients with Pompe, and what we have here is, you're probably familiar with the term BMI, which is what everyone uses for obesity. But that is a pretty poor construct, and you probably read a lot of papers saying how poor it is, but it's extremely poor in neuromuscular patients, and we hope to get this paper out soon, where we realize that many of our patients who appear to be maybe a bit overweight, or even normal weight, or in some cases underweight by BMI, are actually obese. So this is obesity here in gray, and yet none of these patients would be called obese by BMI. In fact, we've had mitochondrial patients come in. We had a lady just last week, her BMI was 17 and her body fat was 54%. So you look at her, push fat, give her more calories, but the patient's already obese. So it's very important to have a quantitative measurement of fat mass and muscle mass. So one of the things that we have used is creatine, and I won't get too much into this, but all of us eat creatine unless we're vegan vegetarians. We get about 1 gram per day. Higher in meat and fish. All of us make between 1 and 2 grams per day from our kidneys, pancreas, and liver. And about 90% of creatine is stored in muscle, and it's excreted as creatinine by the kidneys. Studies have clearly shown increase in fat-free mass, activation of satellite cells, increase in strength and power. It has antioxidant benefits, and it's been shown to improve mitochondrial function. And this has been shown in multiple preclinical and clinical studies. Hasn't been studied in Pompe disease, but many of these obviously would be of benefit for not just Pompe patients, but indeed any patient with a neuromuscular disorder, where some of the issues like oxidative damage, stem cell exhaustion, and mitochondrial dysfunction are common. So we did a study published back in 2006, randomized double-blind trial showing an 8% increase in strength in boys with Duchenne, superimposed on the fact that 50% were taking steroids. So it was additive to the steroids. And if you look here at the Cochrane review, which usually concludes that nothing works, there was about an 8.5% across all studies improvement in patients with muscular dystrophy favoring creatine, and just over a pound increase in fat-free mass. So again, extremely safe. Most of these studies had limb-girdle dystrophy in Duchenne patients, but biologically, the low-hanging fruit, safe. So we put our patients on creatine. But we're looking at other things. So we know that with Pompe disease, FSH, sporadic IBM, DM1, and even human aging, which we've done a lot of work in because it's easier to get subjects and study the molecular aspects, we know the mitochondria don't work very well. And when the mitochondria don't work very well, we get a variety of pathophysiologic mechanisms which may be targetable by drugs or nutrition. So oxidative stress, lower protein synthesis, inflammation, stem cell exhaustion, and impairment of autophagy. So what have people done to look at some of these in Pompe disease? So this was a nice study coming out of Italy that was published just a few years ago, where they showed that both in fibroblasts and in muscle, that there's an increase in oxidative stress. So these are markers of both the production of free radicals and damage to lipids from these free radicals. And what's the problem with free radicals? If they're present in excess, they can damage DNA, protein, and lipids. And you can see this huge increase in lipid peroxidation in myoblasts from patients with Pompe disease. So does that mean anything? Is there any value in giving an antioxidant to maybe help these patients? So what they showed here is that NAC is N-acetylcysteine, which I won't get into the mechanism, is a potent antioxidant, and idebenone is an analog of coenzyme Q10. And what they showed essentially is that in a variety of muscles and organs, in Pompe animals, you could see an increase in GA activity when you gave these antioxidants. Now, it's some weren't stat significant, but pretty much across the board, you can see that this did seem to have a trend towards improving the enzyme activity with the antioxidants. So if you look here at glycogen, wasn't as potent, I think, as they had hoped for, but certainly here in the quad, the heart, and the diaphragm, there is some evidence that with the higher enzyme activity, you're getting more clearance of glycogen. Now, idebenone didn't seem to work. There was no increased clearance, but the N-acetylcysteine seemed to have some mild benefit. So we've done some studies where we've tried to see if we can enhance the benefits of ERT by both improving mitochondria and giving antioxidants. So a lot of our patients years ago were saying, well, we hear that the ketogenic diet is good for you. There's some studies that show that it can activate autophagy. Autophagic impairment is important. Pathophysiologic mechanism in Pompe disease. Let's just go on the ketogenic diet. So we wanted to study this to see for sure. And again, we teamed up with Nina Rabin, who did a lot of our in vitro work, and I'll show you the data. So what we did is we did a mouse study with Nina's GA knockout mice where we gave ERT, and then all of these animals got ERT, but we wanted to see if we added certain things, would it help? So of course, we wanted to check the ketogenic diet. We used this thing called 1,3-butanediol. We used a mitochondrial antioxidant, and then we put them all together, ERT plus this butanediol, which is essentially a ketogenic compound, which activates autophagy, and a mitochondrial antioxidant. So what we showed is essentially this is grip strength. So you can see that the mutant animals, over time, they get weaker. With ERT, we didn't actually measure a benefit, but with the mitochondrial enhancer, the butanediol, and the combination of all of them, we prevented this drop in grip strength. But we also showed that with the ERT and butanediol and the butanediol plus mitochondrial enhancer, we had an increase in rotarod, which is the ability to run on a wheel. Lysosomal glycogen wasn't significantly different, so we didn't enhance the removal of glycogen in this case, but we did lower autophagy. And so what you can see here in particular, these are just markers of autophagy at the protein level. And you can see this huge increase in autophagic block with Pompe disease. And we had significant lowering when we used these two different strategies. The theme in this paper is pretty much when you put everything together, that's where you get the best benefit. And again, it's pretty similar for most disorders, is targeting one pathway is not as good as targeting the multiple final common pathways of dysfunction. And this is the work that Nina did. So green is bad. Green essentially are the engorged lysosomes. And you can see with ERT, there's still a lot of them kicking around. Ketogenic diet, I should point out, didn't do a damn thing. So it didn't help at all in any of our studies except give the animals a fatty liver disease. But again, and this was blindly sent to Nina, you can see a pretty good clearance here with the combination of all of them, certainly compared to the mutant control. And that was consistent with our molecular data showing this improvement of autophagy and improved function. We also showed, this is another marker of autophagic block, showing improvements with the combination therapies. And I just showed you the data from Italy, which came out after our paper came out. So they were thinking along the same lines, showing that there's an increase in oxidative stress, but that is lower with either mitochondrial enhancer, butanediol, or our multi-combination. And this correlated with function. So lowering oxidative stress was associated with a greater grip strength. Removing or lower autophagic buildup was associated with increased grip strength. Any way you looked at it, improving these factors seemed to improve function. Now, can we use 1,3-butanediol? They've certainly tried it in athletes. So people have taken 1,3-butanediol. They say it's well tolerated, and it was published in this paper. The problem is that, yes, you can take this, and this is equivalent to about 2 tablespoons, and you can increase your ketone levels, but we've tried it and we've tried to mask it, and it's really hard. It tastes god awful. But certainly, another similar concept with triheptanone to treat long chain free fatty acid disorders has been commercialized by Ultragenics. And we do have an omega-3 supplement that has a lemon flavor that we've hidden it. So we're working with some folks to see if we can use bitter maskers and flavoring to try and hide the yucky flavor of the 1,3-butadiene for a clinical trial. So with that, what I'll do is just to leave time for questions, because the other stuff here is really therapy. I'll just summarize. So supportively, we identify and treat low vitamins. Vitamin D is the most common thing we see in Canada that's low, but remember B12 is low in up to 15% of our patients. We check folks for hypothyroidism because that's easy to identify and treat. We put people on endurance exercise, and again, go to our YouTube channel if you want to see all the specifics. We do have a channel, I believe, specifically on Pompe, but we certainly have it on myotonic dystrophy and Duchenne. Gait-assisted devices like foot drop, for example, walkers, wheelchairs when needed. Adequate sleep study, especially in Pompe, is important because when you lie down, the diaphragm becomes more important, and that's particularly affected. So sleep studies are critical to ensure that you don't get nocturnal hypoventilation and retention of CO2. Protein, don't listen to the Canadian Food Guide. 0.8 is definitely not adequate for anyone doing any physical activity, and certainly not for anyone over the age of 55, and certainly not for a patient with muscular dystrophy. We always put our patients on 100 milligrams per kilogram per day of creatine. Innumerable studies, probably 10 million people in the world are taking this, showing the safety, and you've seen the Cochrane Review evidence. ERT, again, all of our patients, we offer them ERT. Hard to know what to do based on those studies if they're ERT naive. They do show an improvement in 6-minute walk test. The switching, I think every patient who is not continuing to improve or is showing the typical decline after a period of time on one form of ERT, you should consider switching to another. Health Canada and CADITH are working on what might be available for us. Right now, we can't switch, but we can only start patients on Nexviazyme. Hopefully, we'll see if the Amicus product comes in, and ongoing data might allow us to take a look. Chaperones, hard to know if adding, let's say, miglustat to avoglucosidase is of any benefit. Paper was published, albeit from their competitor, showing that there was no additional benefit in the mouse model. We're working on 1,3-butadiene versus other autophagic enhancers. We think that we have other things that are much more tolerable for patients, and we actually have funding from a kind donation, and we're starting a randomized double-blind trial in January of next year in our patients, trying to evaluate this. We found that the ketogenic diet did not work, so I would not recommend any patient go on that, and there was a huge increase in fatty liver. We tried a certain ketogenic precursor called beta-hydroxybutyrate, and we didn't publish that, but it didn't work at all. So the only one that did work was this 1,3-butadiene, but practically it just tastes so horrible. I won't get into the beta-2 agonist stuff because although it's interesting, and Dwight showed that that enhances ERT uptake by increasing mannose-6-phosphate receptors, we don't have clenbuterol in Canada, so it's a little bit irrelevant for our patients because right now we can't prescribe that. Certainly antioxidants and mitochondrial enhancers are interesting, and that's part of our randomized trial that's starting in January of next year. So if there's any patients that you want to refer, we'd be happy to do that. And then the other issue too is, which is a big issue, is weight gain. Almost 100% of our patients are obese, as you saw, but what are you going to do about it? Because if you do essentially stomach stapling, bariatric surgery, very low calorie diets, or GLP-1 receptor agonists like Ozempic, they're usually associated with a loss of muscle mass. Companies don't want you to see that. They bury it in the supplemental data, but it is a concern moving forward. So what strategies do we have? And we're certainly looking at different proteins and creatine to see if we can prevent some of these deleterious effects that are seen with some of these weight loss strategies moving forward. So I'll leave it with that. And these are all our collaborators, nationally, internationally, and locally. And we started a little late, so I still left 10 minutes for questions. Thanks.
That is great. Thank you so much, Dr. Chronopolsky. Always really interesting. And always rooted in the evidence, and we all appreciate that. A few questions coming in from the audience, so I'll go ahead and read them, and I'll pass them over to you. The first, actually, and I'm sorry if I missed this, and this participant's apologizing as well, which is around Maze Therapeutics. It's MZE001. On the horizon, how does that really factor into what's coming up for treatments for Pompe disease? Any insights there?
Yeah, no insights because I never remember company names. But if you can tell me what the product is, yeah. So there's a whole
I think
bunch
it's
of
an oral, isn't it the oral medication? I can look into it as well. It's
yeah. So we
the
can take another one till we know, because if I know the molecular what the molecule is, because I memorize biochemistry, not what companies make a different product, other than of course the biggies that are making established products. There's a lot of strategies out there. So one of them is substrate reduction. So there's an oral small molecule, and there's a genetic manipulation of glycogen synthase. So I believe that's one of the companies that's making probably the small molecule, which is trying to knock down glycogen synthase. So the strategy with the GS knockdown is that if you inhibit glycogen synthase, you don't synthesize as much glycogen, and therefore there's less glycogen to get caught inside a lysosome. So over a long period of time, these may reduce the total amount that accumulates within the cell. But those are not going to reduce glycogen already inside the cell. That's not going to reduce the already activated oxidative stress and impairment of the lysosomal function from an autophagic perspective. So, I've seen the data, and it must be one of those two companies either using the genetic knockdown or the oral knockdown of glycogen synthase.
yeah, this is the glycogen synthase one.
Yeah. We'll see. I mean, they look great in animals because the animals change so quickly that you can see the decrease over time of not making as much glycogen, and hence less gets stuck in the lysosome. But in a human, it's going to be a very long-term strategy. But again, like everything, I don't think one strategy is going to be the best. If you did ERT plus substrate reduction, plus a chaperone, plus antioxidant, plus improving mitochondrial function, I think that's really what's ultimately going to help our patients.
So another question that actually tends to be popular in that I see three participants asking this, which is they get the sense sometimes from their specialists around not rocking the boat, so to speak, as in being on Myozyme, then sort of not knowing how long they would be on that sort of therapy for, and what would sort of prompt a change. Can you speak to that?
Yeah, I mean, I think, and I don't know why I worry about healthcare resources, I guess because I'm a taxpayer, but I think we have to know with any drug that we give people, is it working? And if it's not working, we shouldn't be paying huge amounts of money from our healthcare dollars for drugs that aren't proven to be of benefit. So my point there is we need objective outcomes. And so in our clinic, we do quantitative strength testing on a biodex. We do a stair climb, get up and go. And some of these don't need to be expensive, like a 4-stair climb, a timed up and go for 10 meters and back is shockingly reproducible. And so we would strongly recommend that you do sitting and supine spirometry. You do some quantitative tests like a 4-stair climb, get up and go, or quantitative biodex dynamometer, and or even a DEXA scan to measure muscle mass. And you can take that data and present it to the patient after a year and say, hey, is this really changing management? Is it worth your going in and taking the risk of side effects and the government money to spend to treat you? So if it is moving forward and you continue to do well, that's great, because we have patients now 7-8 years on who are still 20-30% above where they were 7 years ago on Myozyme. Now, these are usually our compliant patients who have high protein and exercise and take creatine. So I'm not sure exactly what the contribution is, but they're still way above. So we want them on everything. And so we just stay on it. But we have others who, nothing else has changed, check for deficiencies, check for some other factor, musculoskeletal injury, it maybe drop their strength. But if they are going down and you can attribute it to tachyphylaxis or failure to continue to respond, that's when you need to think about switching. Before, we had no option. You either just take somebody off of it, which is not a crazy thing to do if you're not responding. Why waste the money and your time to go and get it done? But I'm hoping as time goes forward, we're going to have two options. One is I can switch to Amicus, try it, quantitatively measure in that person, is it working over the year? If not, I'd consider switching to Nexviazyme or vice versa.
So this is, I think, a great next question, somewhat related, which is around that quantitative measurement around outcomes. And the question really is, how does, in your experience, managing and treating patients with Pompe disease, how does a 6-minute walk test really translate to noticeable or meaningful changes in everyday lives for patients with Pompe disease? Do you find that it is a good proxy or measure for that meaningful, noticeable change in everyday life?
Well, certainly the FDA and many regulatory bodies throughout the world do like it. I was a little negative years ago, but the more I look at things, I think it's a good outcome for clinical studies. I think in a clinical scenario, it is a challenge, and certainly talking to many of my colleagues and from our personal experience, it's difficult in a clinic to do the 6-minute walk test. We can do it in research studies because we usually do it at night or something when the hallway is clear and you can do a nice 50-minute walk, but so many things can interfere with it. So we actually prefer shorter tests. And the test that we like, again, is the 4-stair climb. So time to go from the bottom to the top of stairs, which is really what most of our patients have an issue with. The first thing they say is, you have to use the railing, I have to drag myself upstairs. So that's a really translatable thing that most people do report when they come, that's a problem for them. So I like the 4-stair climb. I like the get up and go, because most people aren't going for 6 minutes. They're getting up and they're going across the room. They're going to the toilet. So I think sitting in a chair, getting up, walking, going around a pylon 10 meters and coming back, it's very reproducible, and it really translates to some meaningful issues for the patients. Because what is the problem most people have? Getting on and off of a toilet. Do you need a raised toilet seat? Can you get out of a regular chair? Can you get up and go to the washroom on your own? So I think those are probably better done in a clinic to monitor someone over a long period of time, and probably more translatable to the activities of daily living that are most impaired with this disorder. And of course, sitting to supine spirometry, done by a person certified by the American Thoracic Society, is incredibly reproducible and very predictive of whether you need BiPAP. So when it drops below 65% forced vital capacity, most patients need BiPAP. And if you go from sitting to supine and it's more than a 25% drop, we know the diaphragm's involved, you need a sleep study. So I would use those, fairly easy to do, quite reproducible studies with the same physiotherapist or kinesiologist employing the test, and use those as outcomes.
Very good. This is probably related to what you mentioned earlier. So definitely in line with use of healthcare resources, really making sure we see the outcome and the benefits, even using the metrics that you just spoke about. Now, with that said, if someone does plateau on myozyme and they're not eligible to switch, and there's really no option to switch to the other treatments at this time point, would there still be benefit in continuing treatment of myozyme? So they've plateaued, they've been on it for a number of years. Continue or go on no treatment?
Well, it's tough. I mean, the drug company would kill me if I said, try stopping it. But we've had patients who have stopped it. For us, we offer to the patient the risks and benefits. We show them the data, and they make a decision. And 3 of our patients decided to stop because they came in and objectively they continued to drop at 3% per year. So they were the ones who made the decision. We don't tell them what to do. They look at all of the data and render their own decision. But it's not inconceivable to say, okay, it doesn't seem to be working for me. Let's try 6 months or 12 months without it. And let's use some very objective measurements, because sometimes you're not sure that it's still working until you actually stop for 6 or 12 months. And then if you have a rate of change that's more than what you would have expected, you say, okay, I've got now objective evidence that even though I was plateauing, and the government might say, well, you're not benefiting, we're going to withdraw support. You come off it and you drop, then you have powerful evidence to go back and say, no, we're confident that the person was getting some benefit, even if it was a plateau. And, we've got some good evidence to support why that person should continue. So I think that's a reasonable choice. Measure, measure, measure. So important.
Is there any evidence, I see a question here in terms of whether to treat early? And so really the question was asking those who were identified with Pompe disease earlier, did they benefit more from myozyme or even any other of the treatments that you mentioned? Is there a clear relationship there?
Yeah, I mean, again, every company would kill me if they heard me say this, but it's the truth. All I care about is my patient's welfare. And they want people to be identified at birth. And it doesn't matter if you have late onset, they want to start treating people at birth. that to some extent from an animal model, we treat before there's damage. We know that it's better. We know patients that are less affected get benefit. However, very practically, let's say you were going to start getting weak at age 50 and might need a walker when you're 70, but you were identified at birth. That means you would go 50 years on ERT. We know for sure that the data is clear that you are going to plateau probably in 5 to 10 years. So what benefit is that to you when your muscle is going to be perfectly fine and probably show no decline whatsoever? So what we do, and I think is a prudent strategy, which fits with the clinical trials, is follow patients, because we have 4 pre-symptomatic folks that were identified by various strategies, and we're measuring them, and they have absolutely no sign whatsoever of the disease, even to the point where we've done muscle biopsies to look at it and don't show any evidence, but we know they have pathologic biallelic variants in the disease. So we follow them very carefully. And what we do is we have a threshold of either a skeletal muscle function drop of more than 15% if they start to show any weakness there, or if their spirometry drops to less than 85% of predicted, then we say, okay, now you're manifesting disease. Let's start the therapy, because remember that every therapy that's been studied wasn't in pre-symptomatic patients. You had to have a forced vital capacity less than 85% of normal even to get into the study. So that's where we know the drugs work. We don't know whether they work. And practically, I think it's stupid to start treating someone at birth who may not have weakness stage 50 for all of the reasons that I've just gone through. Follow very carefully. And when there's some signs of either respiratory or muscle involvement, but you don't wait till it's end stage, right at the beginning. And those folks are going to benefit hugely, because you're going to get them at the very earliest manifestations when there's tons of muscle to respond to the therapy, which is where the benefit would be seen.
Yeah, and I also see in the chat a few saying that they were also compelled by the evidence around exercise or rehabilitation, and even ahead of sometimes a pharmaceutical agent or treatment to see potential benefit there that aligns with their time of diagnosis. Just one last question that I'd love to get to, which is the person's asking whether intermittent fasting is a way to initiate autophagy at all. Any evidence there?
Yeah, the problem with that is, it's all the hand waving with all the anti-aging folks and stuff like that. And, you starve yourself for 16 hours and, you go into the fasted state, your epinephrine goes up and you activate autophagy. However, there's other ways to do it. I mean, exercise for sure. And the downside of fasting for a long period of time, it gives you a pretty narrow window to get all of the adequate protein. Because on the flip side, many aging individuals and many patients with muscular dystrophy aren't getting enough high quality protein. So you would have to ensure that you're getting, 1.2 to 1.4 grams per kilogram per day. And the other issue too is there's so much garbage out there about, collagen protein and plant. I mean, nothing against plant. You can very carefully get enough amino acid, but the best proteins are eggs and milk in terms of the biological value. Next are fish and meats. And then far below are things like collagen and plant-based. So a lot of people who do the intermittent fasting are also on very low quality protein, which is not good from a muscle building perspective. So I think, it's something that I would be very cautious to use. We're looking to see whether certain natural ingredients can activate the autophagic process. But I think your best way to do it is with exercise, because we know you get all the other benefits too.
Well, as always, thank you so much for a really straightforward, candid, and well-delivered talk. We'll definitely keep you posted if there are other questions, but really, really appreciate it. You're always willing to share and impart this knowledge. So excellent presentation. Thank you so much for your time. Have a good day, everyone.
Have a good one.
Take care.
Have a happy Remembrance Day. And remember all those lovely people that have sacrificed things for all of us to be here safe and sound as Canadians.
Absolutely. Well said. Thanks, everyone. Have a good day.